game-changing discussions on the big ideas that shape our thinking. This is One2One.
Dr. Abuchi Okaro is a consultant general upper gastrointestinal and metabolic surgeon, and previously consultant surgeon at Maidstone and Tunbridge Wells UK NHS Trust. He's a pioneer of weight loss and bariatric surgery in West Africa and co-founder of one of Nigeria's first dedicated diagnostic and therapeutic endoscopy centers. His work has changed thousands of lives, reshaped what is possible in minimally invasive surgery, and helped build the foundations of a new era of metabolic and gastrointestinal care in the region. Abuchi Okaro, welcome to One2One.
Thank you. Thank you. Thank you for joining us. Thank you for inviting me.
So you pioneered metabolic and bariatric surgery, metabolic weight loss surgery, bariatric surgery services in Nigeria, didn't you? You've been coming back since the 2000s to do this side by side with your consultant job and everything else you were doing in the NHS. I'd like to know, we're moving on to talk about obesity here. What do you think most people still misunderstand about obesity as a disease? And first of all, is there even an obesity epidemic in Africa?
I think you were really precise in that description. It is a disease. And I think that's a misunderstanding that I think a lot of the international sort of community have been working hard to define it in terms of nomenclature, in terms of diagnosis, and then of course subsequent kind of treatment.
Yeah.
So yes, that really was a bit of an obstacle in the definition of obesity as a disease rather than as a condition. So that's the first thing. And I think Nigeria is, incorporated into that. But I think, the reaction or the response to actually, obviously, why is there an epidemic or is there an epidemic? I think clearly there is. It's global. Of course, Nigeria has a bulk share. But the other way of looking at it is looking at some of the consequences of obesity, let's say hypertension, for example, or type 2 diabetes, then, polycystic ovarian syndromes and the infertility, and then, and so on. So if you're looking at it through either lens of the outcomes of being obese or the actual condition itself, it's just getting worse. And also, as I'm sure you would probably want us to touch on, is the childhood obesity. I mean, in Nigeria and globally, it's very concerning.
Absolutely. So you just described for us, and you laid a fantastic foundation for many of the other things that we'll talk about in this conversation. You've just described for us a constellation of conditions and diseases that revolve around obesity. You talked about type 2 diabetes, polycystic ovarian syndrome, talked about hypertension. So we're moving on to your work now. These are metabolic conditions or diseases. So leading on to your work as a bariatric surgeon and doing weight loss, obesity surgery, can you help me understand what that is and why that has a place in amongst all of this?
What we do is we do some procedures on the upper gastrointestinal tract, which is to either make the stomach smaller or make it smaller and then do the bypass, which essentially means that we either restrict, which needs calorie restriction, so the quantity and the volume of the food that one can consume on any this particular sitting goes down.
By reducing the size of the stomach.
By reducing the size of the stomach. A classic case would be like the lap sleeve gastrectomy, for example. And then that has some added benefits. So not only are you now not able to eat, you eat less, but you're also having some changes in the physiology and biochemistry of the body. So ghrelin and so on, which is to the brain and the nervous system, which makes you less hungry. It also makes you get full quicker, which ultimately then means you eat less. It also speeds up your digestion, which means that you have but the ultimate point is that you eat and consume less and your body handles calories in a slightly different way. And the impact of that is weight loss over time. So that's what the classic restriction does. Now, when you add in something like a bypass or a switch or so, what you're doing is you are now excluding a portion of the very long digestive small intestine tract from absorption. So let's say a gastric bypass, for example. And the bottom line is that there's certain foods that will come through and not be absorbed. And ultimately you end up with again. So it's all about getting less calories, less want for food, which is an addictive behavior change. And of course, changing the body functional processing of sugar through insulin and so on. That ultimately allow people to lose weight. Yeah. So that's the way we fight obesity with, let's say, surgery. So they're the two big ones, bypass and sleeve are the two big operations. And there are other operations which we don't really need to kind of touch on. But the point is we want to empower or enable a patient or an individual end up eating less over time, consequently lose weight, and hopefully maybe get their health better.
So just by way of laying a bit more foundation for what we'll go on to talk about next, we're talking that acknowledge the fact that there's certainly is a global epidemic obesity. Nigeria has it, and Africa has it fair share. There's a direct link with type 2 diabetes, a number of other conditions that we would call metabolic. And there is a benefit to what you do, bariatric surgery, weight loss surgery, amongst other options, complementary therapies. But I'd like to ask, particularly in this environment, Nigeria, Africa, where is that obesity coming from? You talked about childhood obesity, for example. What is the genesis of that obesity in this environment?
It's definitely multifactorial. It's coming from different kind of areas. I think if we focus on the adult obesity, I think, and then maybe talk a little bit about the childhood obesity. Eat a lot more processed foods, which is part of the westernization of our diets. Even the Nigerian diet, sadly, particularly the kind of they're very carb heavy. So there's a lot of bread, there's a lot of rice, there's a lot of fufu. These are all very rich carbohydrates. And they are staple diets for home. So not a surprise, the yams and so on. So we're very carb heavy in this part of the world. We also traditionally we run kind of fairly sedentary lifestyles. We're not as active as we could, partly because, of course, some sort of restriction. We're trying to get to work and earn a living. And then also, we have an extremely vibrant sort of beverage industry. You can get Coca-Cola or beer or lager. So I think it's like that. Yeah. I think it's just, you have to actually step back in order not to indulge, in order to prevent, I think, getting into the trap. So I think that's a big for the adults. The children, I think it's the same as the adults, but I think in children's case, I think you got to add in the snacks and the sweets. There's a lot of sweets going on, snacks, and I think that just carries on all the way through to school. So, yeah.
So it's a deeply personal subject, isn't it? Not just clinical or even presentational. It's very deeply personal, isn't it? The question of weight and obesity and layered in and amongst it, and all of that, of course, is a plethora of disease conditions revolve around it as well. So it really is a very, very important subject, and no wonder it's topical, particularly now.
Because it's treatable. It's reversible to an extent. Some of these are reversible conditions. I think we haven't really delved into the science, but the science suggests and very clearly demonstrates that, if you begin to correct some of these conditions, there's certainly a significant improvement in quality of life. There's a significant reduction in cardiovascular mortality. There's a significant reduction in cancer incidence and mortality. There's a significant incidence on need for joints and hip. You talk about self-esteem, you talk about mood, you talk about just life experience. So if you're looking at the science of it, I think there is just no doubt.
Absolutely. So we're really speaking about a very important subject here. And moving on to the topicality of it all, we've spent a lot of time talking about the constellation, of course, of diseases and conditions that revolve around obesity, the impact both psychologically and clinically, and some very, very deep personal experiences you've shared with your patients here as well. But of course, these days there are what some would call alternatives to surgery. And I say that deliberately because I know that you will want to recalibrate the thinking here. The rise of GLP-1 agonist medication, talking about Mounjaro, Ozempic, it sparked a global debate. And these really are, it's diabetes medication, isn't it? So how do these compare to surgery in terms of metabolic durability, or how should we view these new treatments?
So I think on really key, you're 100% correct. The rise of these small molecule compounds has really transformed the market, and I think to put it we got to put it in a sort of a global perspective. Obesity, in terms of incidence, is so large, so massive, that you clearly need to have a ladder or kind of a scale for intervention. Because if you're looking at just unbelievable volumes, so I think that's the lens upon which I would probably kind of answer that question through, really. So these small molecules are really they're amazing. They have really changed the landscape for all comers, because that's how it sort of became. It's like all comers, try this. So over the years, of course, some of the big communities that we know in bariatrics, IFSO and some others have been watching and of course researching, because there's a huge amount of research going on behind the scenes. And I think what they're coming through to now agrees that there is an algorithm. Are you with me? Whereby if you look at the advantages of, let's say, Ozempics or the Mounjaros and compounds like them and the ones to come, because they are more to come, clearly. And then you look at the ability for us to what they can achieve, certainly in the short term, you really begin to see some difficulties now. I think Mounjaro data is about 15% total body weight in total, 15, maybe 18% at best. Ozempic is about loss in the best cohort of studies. I think Ozempic's about 10%, maybe 12. And you got to keep using them again and again and again. So when you look at that data, you really then see that people who have a certain amount of weight that needs to be lost based on, let's say, body mass index, for example. I'll give you a practical example. Somebody with a BMI of 50. Morbid obesity, super obesity. Trying a GLP-1 as a primary treatment is just a waste of time. You're never going to get them to the weight that's going to, I'll put them in a better category. Are you with me? Now, somebody with a BMI of 30 or 34, okay, yeah, worth it. So that's really what I think is coming through in conversation. But the other thing that's coming through that's really interesting is they're working synergistically. So we're using them together. Particularly either to prep people towards surgery to help them lose some weight, because of course they may well be a bit of a morbidity issue. You may be looking at a situation where, for example, they have had the interventions and their weight might be coming back a little bit. You can then add it in. So it's becoming a bit like chemo and surgery therapy. In a way of speaking, you're combining therapies. So that's where we're at the moment. But I must add, the very important thing, I think it's more for patients in terms of their understanding, or at least their awareness, is that the problem with some of these compounds is that patients are taking them, and we're not talking about the side effects now because they're very few, but they are serious. But they take them, what they end up doing, sadly, is in as much as they benefit from them, they lose a combination of both muscle and fat. because that's what these compounds do. You lose muscle bulk, you lose fat. And then what happens is if they stop the drugs, which you usually do, what they gain back is fat.
Absolutely.
So what happens is they've followed some of the long-term group of patients, and what they end up doing is that even though they rebound weight, they're rebounding as strictly fat. So the sarcopenia risk gets significantly higher, which is why they encourage you to, be part of a program, to do it with a nutritionist plus a physician who's going to advise you on exercise, making sure you're training up your muscles, your protein intake, and so on. But we won't go deep into that.
Of course, yeah.
But that's where I think concerns are coming.
Yeah. So Abuchi, talk me through. You are a surgeon, a practitioner of international repute. And we're talking about a complex subject here, complex therapies as well. So talk me through, help me understand the evidence-based algorithm or the procedure for prescribing these medications, or where surgery has a place. You talked about BMI and things like that earlier. Educate me properly from start to finish.
So in my practice, so what we do at our center is that a patient obviously this is when they come to us. So this is not people ordering on Amazon. So it costs us, and they come and say they want to lose some weight. And we have a consultation with them. We firstly establish what their current weight is, and then their BMI, and I think any comorbidities. And then we really, I think the key question always for me is really, what's your target?
Yeah.
What journey do you want to get in terms of your weight?
What's your target?
Yes. So that's always my starting. So if a patient comes in X weight, what's your target? Now, if they tell me their target, the gap between their target and their present weight isn't going to be delivered by, let's say, Ozempic or Mounjaro, I make that very clear based on the data. Are you with me? Now, most of the conversations would go, so alternatives. And then we go through them. So I have to give them, the full, we always give them the full kind of optionality. Now, for patients who are super obese, so I know that their risk, either because of chronic obstructive sleep apnea or massive bad hypertension or diabetes, will be that their perioperative risk category puts them at severe, which means that their risk of getting complications is strictly higher.
If they go and
destroyed direct to surgery, I would not operate on them, because of course that would impact on outcome.
Of course.
So then I would use, let's say, Ozempic or Mounjaro to reduce their weights pre-surgery, and then advise them, and then that's a very easy, comfortable way of using it. Now, we also have patients who, despite all conversations, insist on having, the GLP type, and then we would prescribe them for them for a limited period to see if it has an impact.
What does that mean? What's a limited period?
Depends. I mean, normally it's 2-3 months, because you can obviously move the doses. Now, I haven't added here, which is kind of very important to state, that I think they are, in my experience, they are usually 3 categories of patients. In my experience. The first category of patient is as a patient who is as well researched, done their homework, very informed, but has an open mind. And they come, we have a conversation because we, with a nutritionist, myself, and always together at the same interview, and we inform, and they kind of, take on board our, the data, and go home and come and then comply. Usually. And there's a second category of patient who has done their research, but are very emphatic, very, very clear. There are some no-go areas. I am not going to have an operation, doctor.
Absolutely.
You can't convince me.
Yeah. You get them all over the world.
Correct. So once they make that clear, and I always establish that early in the conversation, because it saves time, you then really know your options on the table are those GLP-1s, maybe a balloon or nothing. And then there's a third category of patient who isn't informed, but also doesn't know what they want, and has no restriction. So they require a lot more work, because you have multiple conversations with them. So they're the 3 that I tend to kind of try and seek out very early in the conversation so that, we can.
Certainly. So we earlier on, we talked about where this epidemic is coming from. We spoke about diet. We spoke about childhood obesity. I'd like to delve slightly deeper into that. I mean, we're talking really about patients or individuals long before they come to you. What really should people be eating or not be eating in order to prevent the prospect of meeting Mr. Abuchi Okaro at some point further down the line?
This is the childhood obesity, right?
Yeah. Start with childhood and then you can go to adults.
I'm a nutritionist, obviously. Cherise, who's my nutritionist, I'm hoping will agree with my comment now. But essentially, I think we have to look at the big offenders, processed foods, richer fast foods to a large extent.
Yeah.
To a large extent.
And we're becoming an increasingly affluent society. These things are readily.
We're all in a rush. There's no time. Of course, there's they tend to be a little bit cheaper because, of course, they are, the ingredients aren't the most wholesome, and they're usually carb based. They're majority carb based, or they're fried, deep fried or stewed. So once you know that, then you want to move them to slightly more wholesome foods. So they're going to be foods that are either grilled or boiled, less fried, roasted. You start in that category and you kind of move them away from the carbs towards, something a little bit more protein-based, potentially, or fiber-based, salads, lots of fruits, not the liquidized fruits, no fruit juice. You want them to have the raw fruit with the fiber, and so on. And then you want to get them out exercising and sticking to water, hydration, for example. And I think, so yes, my approach should be to be looking at trying to make your food a little bit more towards a protein, good fats, fiber diet, and then the carbs, and then getting out and moving around, particularly for the children, but also for the adults. But the bottom line is we're all addicted. We all have an addiction. Let's cut to the chase. We all have addictions to some degree. So we always try and get them to make their addictions positive. Make them constructive to their well-being if they have longevity in their view. These are the adults. The children, of course, is parental, of course. Sadly, children who tend to be more overweight tend to come from slightly more overweight families traditionally because of what's in the kitchen, what's in the pantry. It's habit, right? So it is repetitive, subconscious, automatic, knee-jerk, no thinking behavior. So it all goes to behavior, sadly. But then that means behavior can be changed, which is perfect, which is why the psychology gets important. The counseling, the coaching, the conversations, and the emotionality of it, which is why a consultation that I would have with Cherise and my patient could take an hour. I deeply want to know really if, what's going on, where are the traumas, and if you have a good patient rapport, this is the bit that comes out in studies, which is really quite powerful, which is why you have to always be, self-aware as a clinician yourself, is that the patients do things for their doctors deeply. If they have a true connection to their doctors and their clinicians, there's data suggesting they do more for the doctors and the nurses that they care and feel they like. So that's been proven.
Absolutely. So, Abuchi, you recently published a 10-year retrospective study of metabolic surgery outcomes in Lagos. You're beaming. You're very proud of that. 381 of your own patients. Okay. So tell me, what were the most important insights from that data set? And how important is local data, by the way, in shaping safe, sustainable bariatric programs in Africa?
I think it's essential. If you recall, I alluded to the gap in the Sub-Saharan region, and it's been a real discomfort for me over the years to see Sub-Saharan Africa, with the exception of South Africa, put in a basket case when it comes to bariatrics, for example. So to get my data out, I think was really important. It's, it's not not massive numbers, of course, but I think it is still a line in the sand to say, yes, we have been doing the work. So I think that was
an ATY.
So for me, that I think was quite a task, and I'm so grateful for all of my kind of colleagues and those that help me do that really. So that it is important. I think we need the narrative change, which is, I think, what you alluded to has to happen, but it isn't soft. It's got to be based on hard facts. The thoughts, anecdotes just don't cut it in the world. You've got to have hard facts, which means that the data's got to be collected, if you can, prospectively. It's got to be verifiable. Now, if the data is collected and it proves that the results are acceptable in international standard, which luckily ours are, then I think it's something to be proud of for the region, really. So yes, I think it is really an important landmark paper that we were luckily able to get published. And as you know, I specifically choose to publish it in Africa.
Absolutely.
I did not want to. I didn't want to publish it in Europe. I was very specific. I said this has to be published in an African journal. It's African data.
Important to tell our own stories.
I didn't want. So I definitely wanted to be published in Africa.
So it's a good time in the conversation to talk about leadership, legacy, and your personal reflection. The entire discourse has been a reflection, hasn't it? So you founded the Bariatric and Metabolic Surgeon Society of Nigeria. Can you tell me what gap you felt needed to be filled there, and why now?
I believe it was in 2022. I had a difficult, challenging patient. And cut long story short, it was clear to me, and I actually remember vividly, I was in my car driving to the train station. I was back in England then. And I said to myself, I said, look, you need to start a movement. And it just hit me. I thought, now, what did that mean? What that meant is I thought we needed to have better support. I was solo, on my own, pretty much, trying to do this with, and I wanted to bring my younger colleagues and other colleagues together. I'd trained a few surgeons by then, through the sort of the mentorship schemes at Eurocare at the time. So I thought, let's all come together. So I went on, founded a society. It's 3 to 4 years old now, and I think it's been helpful. I hope it's had some impact. So yeah, I think it's just to help support really each other, guide. I think each other. It's a hard world out there in bariatrics and metabolic surgery in Nigeria. I've found that out many times, and you need a friendly space. I think.
Abuchi Okaro, thank you for joining us in Q1 to One.
Thank you. Pleasure. Thank you.